All right, welcome back. This week, moving on to Chapter 22, Rehabilitation and Reconditioning. We're in the home stretch now, so after this chapter, there's only two left. There's one on facility design and then another one on legal issues and policies and all that kind of stuff. So almost done. With respect to rehab and reconditioning, if you're working as a strength and conditioning coach or strength and conditioning professional, as they always say in this textbook, one of the things that you're going to do is to probably work closely with the athletic trainer from a rehab standpoint. So you're not, going to be on your own doing rehab, but typically it is after the athlete is pretty close to being ready to return to play, then they're going to start working with you and they're going to be doing more of their sport-specific drills by the time they get to you. So as a strength and conditioning coach, you're probably not going to work with athletes early in the rehab. That's going to be mostly the athletic trainer and or the physical therapist. And then, like I said, once they get to you as the strength and conditioning coach, it's going to be pretty close to their time to return to play. And so you're going to be doing a lot of really sport-specific stuff with them. But nonetheless, this chapter kind of gets into some of the details about tissue healing, goes into great detail about the various members of the sports medicine team, and then has some specific terminology that you want to be familiar with, things like open and closed kinetic chain exercises. So in terms of the overarching principles of rehab and reconditioning, the first thing there is that the healing tissues must not be overstressed. So after an injury, we'll talk about the different phases of tissue repair, but in that second phase, like right after the acute inflammatory response, you're into a fibroblastic repair phase where the fibroblasts, which are the immature connective tissue cells. So remember, thinking back to 201 and 202, blasts are immature cells. So fibroblasts are immature connective tissue cells, similar to osteoblasts in bone or chondroblasts in cartilage. All of those blast cells lay down a lot of the extracellular matrix, and all of them generate lots of collagen. So in the case of fibroblasts, those are cells found in connective tissue like the loose areolar tissue, or they're found in tendons and in ligaments. And so those are going to be the cells that generate the collagen. So after an initial injury, typically starting about 3 days after the initial injury, those fibroblasts, their production of collagen is going to really ramp up. But the type of collagen that they produce is a type of collagen that is not especially strong. It's type 3 collagen. And so one of the ideas there is that even though the inflammatory process has subsided, so their swelling has largely gone away, the injured area is not all red and painful anymore, we don't want to go nuts and overstress that collagen that's not very strong and that's not really aligned along the lines of stress of the injury, because potentially we could re-injure them, right? And so that's one of the overarching principles, is the idea that we don't want to apply too much stress too soon and thus exacerbate or worsen the injury. The second thing on there is that the athlete has to fulfill specific criteria to progress from one phase to another. So a lot of what we do from a rehab standpoint is the athlete has to check certain boxes to move on to the next phase of their rehab. So for example, I wouldn't have an athlete do balance exercises before they had a certain amount of strength. Let's say, my go-to example for this whole talk is going to be if somebody has a lateral ankle sprain, which is your typical inversion ankle sprain. So let's say somebody sprained their ankle. Before I put them on an AirX pad, which is like that blue squishy pad, and have them do a bunch of balance stuff, I have to make sure that they have good strength around the ankle. So I'm going to spend a lot of time before that doing things like using TheraBands or special rubber bands to have them go through different ankle range of motion exercises and resisted exercises. And once they have sufficient strength, that's my criteria here, then I'm going to have them do proprioceptive or balance stuff. And then once they're good at both of those things, now I'm going to have them do maybe some plyometric stuff where we have them do some hops and those kinds of things. But they can't obviously do one-legged hops if they don't have balance and they don't have strength. And so that's kind of the process of rehab, is once they've checked certain boxes, once the swelling has subsided, once the inflammation has subsided, now we can do isometric strengthening, then we can do isotonic strengthening, and then we can do balance, etc. So that's kind of the general process for how things work. So the program has to be based on science and all of that stuff. in reading that, one of the things that came to mind is that you're seeing things like ice kind of fall out of favor. So, if your experience as an athlete was anything like mine, it was anytime you get injured, put ice on it, right? And that's not necessarily wrong. But one of the things that ice does is to probably cause vasoconstriction, causes blood vessels to close down, and limits swelling. And so the idea there was that if we could limit swelling, then we could limit pain, and then we could have them start doing range of motion exercises and start being active a little bit earlier. But the more contemporary school of thought is basically that you don't want to do a bunch of things that tamp down inflammation. So you don't want to give them a bunch of anti-inflammatories like ibuprofen, for example, and do a bunch of ice and stuff, because then that's going to interfere with the inflammatory process, and the inflammatory process is actually an important part of healing. So we don't want to do a bunch of stuff to tamp that down, because potentially that's actually going to lengthen the rehab process. So while athletic trainers and physical therapists do still use cryotherapy, aka ice, there's other cryotherapy techniques, but basically anything that causes cooling, it falls into cryotherapy. So while everybody still does use ice some, the primary reason that people use it now is to reduce pain, to allow for range of motion exercises and those kinds of things. So people don't do as much icing as they used to. So like before, and this is 10, 15 years ago, really aggressive icing would be like you ice for 20 minutes, take off for an hour, ice for 20 minutes, take off for an hour, and then you just do that for the first, give or take 3 days after the injury to really work to minimize that swelling. And so people don't really do that as much anymore. They'll basically do some icing to minimize the pain, to allow for range of motion, and then the range of motion itself should help to minimize the swelling, which hopefully then reduces pain. In terms of team-oriented approach, that's what the next several slides are about all the members of the sports medicine team. Now, one of the things I would point out is that if you're at a big university, so if you're at Madison, if you're at Michigan, Notre Dame, etc., you'll have all these members of the sports medicine team, but if you're not, you probably won't have all of them, and you may only have like 2 of them. So we'll go through those. So one of the things is that all the members of the team obviously have to be able to work together. They got to communicate well to ensure that the athlete recovers from the injury and that they're ready to return to play. And hopefully when they return to play, they'll be pretty close to their pre-injury level of performance. So the first member of the sports medicine team is the team physician. So the athletic trainer usually works under the team physician. Like they, in some states, have to practice under the license of a team physician. So what they do then is, like, let's say, again, to use my example, they have an athlete who has a lateral ankle sprain. One of the things that the athletic trainer will do is to say, okay, I think this athlete sustained a grade 1 lateral ankle sprain. And they'll tell the team physician, they'll tell the coach, and then in telling the team physician, the physician will go, okay, great, you handle it. Or they'll say, I don't know, that maybe that's a little bit more severe than a grade 1. Maybe that's something I should take a look at. Why don't you, bring them into the office, and then we'll do some x-rays, or why don't we make sure that I take a look at them the next time I'm on campus, those kinds of things. So the team physician is the one who has the biggest say in how injuries are handled, also in referrals. So like I said, everybody kind of works under the team physician to a large extent. The athletic trainer does most of the day-to-day stuff. So the athletic trainer will usually do the initial injury evaluation, oftentimes determine or play a role in determining the need for referral. Does this athlete need to go see an orthopedist? Do they need to go see a gastroenterologist, depending on what they got going on? Those kinds of things. So most of the rehab is going to be handled by the athletic trainer at most places. Now, at some places, like bigger schools, like in professional sports, you'll have individuals that are dual credentialed. They'll be both an athletic trainer and a physical therapist. If you don't, typically the more intensive rehab is handled by the physical therapist. So, if you're working at a high school and you do have an athletic trainer, but you have an athlete that is recovering from an ACL tear. So let's say they tore their ACL and then they had surgery. Most of the early phase of that rehab is going to be handled by a physical therapist, typically in an outpatient clinic, and then the rehab gets transferred more to the athletic trainer. The athletic trainer is going to do some stuff with them early on, but usually there's essentially a handoff from the PT to the athletic trainer, and then they'll make their way, like I said, when they get close to return to play, they'll make their way to the strength and conditioning coach. So typically PTs handle the most intensive part of the rehab, like the early post-surgery kind of stuff is usually the PT. Strength and conditioning professional, really long stuff there, but the idea, so strength and conditioning professional or coach does performance enhancement programs, so trying to make the athlete bigger, faster, stronger, more powerful, all those kinds of things. But strength and conditioning coaches also do prehab, so their program, let's say for a soccer team, may include a lot of like plyometrics and landing exercises and lateral hip strengthening and core strengthening to try to minimize the risk of ACL injuries. So strength and conditioning professionals can play a really important role in prehab or injury prevention as well. Physiologists you're not going to have unless you're at a big school, but the physiologist will kind of assist or work, not assist, but they'll work with the athletic trainer, they'll work with a physical therapist to ensure that the athletes, usually they do a lot more of the cardiovascular stuff, but that the athlete's conditioning is sufficient to return to play. Nutritionists or dietitians, they're going to handle the meal planning, if you will, and again at a bigger school. But so big schools like Madison, like Michigan, etc., will have dietitians on staff, and so the athlete will work with them to maybe gain weight, to maybe lose weight, and then post surgery or post injury. Sometimes the dietitians will put them on like anti-inflammatory type diets, where they'll have them do a lot of things like a lot of antioxidant-rich foods, a lot of things like green tea, turmeric, all kinds of different stuff. And so the dietitian will be the one who makes that or who makes those recommendations. The psychologist or the psychiatrist, so typically team psychologists from a rehab standpoint will work with athletes on like fear minimization. So if you had an athlete who had injured themselves, let's say you got a gymnast who fell off the beam and had injured themselves, one of the things that the psychologist will do is to, maybe they've got some anxiety related to that when they go back out and try to perform. So the psychologist will work on helping them to overcome that anxiety associated with that particular traumatic event that they fell off the beam and injured themselves. Same kind of thing, like there's a saying in sports medicine sometimes that it takes a year to physically recover from an ACL tear, but 2 years to mentally recover. And so that's another thing that the psychologist will work with them on. And so you'll see athletes, even though they've been cleared, sometimes shortly after an ACL tear, they'll go and they'll be really hesitant to cut. They won't put a lot of weight on that leg, like during actual gameplay. And so the psychologist will work with them on that of ensuring that they're comfortable performing the things that they need to do for their sport. So things on here. So there's a couple of important terms here, indications and contraindications. So I usually start with contraindications. Contraindications are things that you're not supposed to do. So for example, if somebody is immediately post-injury, they sprained their ankle yesterday, resistive exercise would be contraindicated. It'd be something you're not supposed to do. So if they just sprained their ankle yesterday, you don't want to put a TheraBand on their ankle and have them do a bunch of resisted exercises, because that's actually going to make the injury worse, right? So it's contraindicated in that case. If you have somebody who has an allergy to aspirin, it's called Ray's syndrome, then giving them aspirin would be contraindicated, something you're not supposed to do. So on the opposite hand, then, indications are things you are supposed to do. So with the ankle sprain, then things that would be indicated immediately post-injury, some ice, but also some range of motion, compression, elevation, those kinds of things. Those would be treatments that would be indicated at that point in time. Obviously, the coach has to communicate with all the other members of the sports medicine team. Now, obviously, the strength and conditioning coach isn't going to work super closely with the team physician, but they are going to work really closely with the athletic trainer and oftentimes people like the dietitians or the sports psychologist. Some more terminology here. So macro trauma, anything macro is big. So macro trauma is big trauma. So it is if somebody gets what we would refer to as a traumatic injury. So that's like a broken arm. That is an ankle sprain. That is a shoulder dislocation. Those kinds of things. Those would be all macro trauma. So there's one big inciting force that causes an injury. That's a macro trauma. So, in the case of a shoulder, somebody, one of your defensive players in football tried to make a tackle with their arm and abduction, and then it got pulled into external rotation, and their shoulder got dislocated. That's a macro traumatic event, right? So it's more commonly referred to as a traumatic injury, as opposed to an overuse injury that we'll talk about here in a second. So dislocation, as you can see, a complete displacement of the joint surfaces. So shoulder dislocations are fairly common in most sports, particularly contact sports. So in a shoulder dislocation, the humeral head rolls off of the glenoid. Typically it rolls anteriorly and inferiorly, so forward and down. And so those two joint surfaces aren't touching each other anymore. So that's a dislocation. A subluxation is a partial displacement. So shoulder subluxations are also fairly common, especially if you've had previous dislocations. So shoulder subluxation, the humeral head will slide part of the way off of the glenoid, and then it'll slide back into place. So typically when somebody has a subluxation, it feels like their arm just kind of goes dead. They may hear and feel a click, and then they'll have a sudden reduction in strength. Those are kind of the typical symptoms of subluxations. Shoulders are the most common places for those. Other subluxations, sometimes we'll get one of the patella, so the kneecap. We're able to go part of the way out of that, the groove on the femur, but then it'll pop back. It presents very similarly to an ACL sprain, where they changed directions, they felt like their knee gave out, they heard and felt a pop, but then there's nothing really wrong with them. So the joint still has good stability. Then that may be a patellar subluxation. Sprains are injuries to ligaments or joint capsules. So it doesn't say joint capsules on there, but those are included. So if an athlete injures their anterior cruciate ligament, their ACL, that's a ligament injury, so that's a sprain. So sprains, capsules, and ligaments. Like I said in another class, one of the things I always think is funny on injury reports is sometimes you'll hear like, oh, he just sprained his knee. Like, well, okay, but that could be an ACL tear, so that could be a year plus rehab. But okay, he just sprained his knee. So a sprain, again, capsular ligament, as opposed to a strain. We'll come back to contusion. So a strain is damage to a muscle or tendon. Remember that a tendon is how a muscle connects to the bone. So a strain is an injury to either of those structures. Both strains and sprains are classified first, second, or third degree. Basically, a first degree is either an overstretch or a very small level of tearing, depends on what muscle we're talking about or what ligament we're talking about. But generally, think of a grade 1 as an overstretch. Think of a grade 2 as a partial tear, and then a grade 3 as a full tear. Like I said, there's some variability. Like with the hamstrings, like a grade 1 is less than 25% of the fibers torn. Grade 2 is like 25 to 80% or something like that. So it moves around a little bit, but kind of the easiest way to conceptualize strains and sprains and their classifications is, like I said, grade 1, overstretch, grade 2, partial tear, grade 3, full tear. Contusions are bruises. Not really sure why they phrased it this way, but a contusion's a bruise. So typically a traumatic injury, big force, you're compressing tissue. Micro traumas, so anything micro is small. So micro traumas are best thought of as microscopic damage to a structure. So micro traumas, the way that they're using it is associated with overuse injury. So for example, in structure, let's see, that's structure 1, where we talked about bones, we talked about that within the collagen fibers in a bone, you have these sacrificial bonds that, as the bone is compressed, you'll get some breaking of the bonds between these collagen molecules, and that allows for some shock absorption. And so that shock absorption helps disperse the forces without allowing for a macro trauma. But so you get this little microscopic damage to the bone after, let's say a big plyometric session, for example. And then if we turn around that afternoon or maybe the next day and we do the same thing again, then you're going to get more micro trauma on top of what's already there but hasn't been able to repair itself. And so if we do that over and over and over again, eventually that micro trauma becomes macro trauma, and so then that becomes a stress fracture. Other things with micro trauma are other overuse injuries. So things like tendonitis is related to or caused by micro trauma as well. I'm trying to think what else. Those are kind of the big two: stress fractures and tendonitis. You can get tendinosis. You can get variations on tendon or tendon sheath injuries, but all of them are basically from micro trauma. Speaking of stress fractures, there's that, and tendonitis, there's that. All right, so 3 phases of tissue healing. So there's the inflammatory phase, sometimes referred to as the acute response phase. Typically, the inflammatory phase lasts for the first, give or take, 3 days of the injury. So the inflammatory phase we associate with things like swelling, redness, pain, point tenderness, meaning if I poke the injury, it hurts. All of those are things that we would associate with that initial inflammatory response. That typically calms down, give or take, around day 3. Again, depends upon the type of the injury and the severity of the injury. Like with an ACL rupture, it's not going to calm down quite as much by day 3 as it would with, let's say, a grade 1 lateral ankle sprain. But approximate windows here. Then we move on to the fibroblastic repair phase. So the fibroblastic repair phase starts, give or take, day 3 and can last several weeks. And then we get into the remodeling phase that can last several months. So how long each of those things lasts, each of those phases lasts, varies, as I mentioned. So it depends upon your age. Obviously, as you get older, so you're more mature athletes, so your athletes, more like middle age or even later, it's going to take them longer to heal. So for example, as we age, your tendons become less vascular, so they don't have a ton of blood vessels to begin with, but the number of blood vessels that they have decreases with age. You also lose fibroblasts in the tendons with age, so they just get less good at repairing themselves. And so an athlete may then be or a middle-aged and older athlete is more predisposed to developing tendonitis than a younger athlete, and then it tends to stick around for longer as well. Related to lifestyle, if you're better conditioned, then the injury healing time tends to be a little bit shorter. So if a sedentary athlete or sedentary individual, goes out and overdoes it one time and gets tendonitis, it's probably going to take them longer to recover than somebody who's well conditioned, because those things that I just mentioned, where the tendon gets less vascular as you age, you lose fibroblasts with age, that is all true, and you can't stop that process. But the more active you are and the more consistently active you are, it kind of slows those losses down. So somebody who's been consistently active is going to have more blood vessels in their tendons than somebody who hasn't. They're going to have more fibroblasts than somebody who hasn't. And so they're probably going to heal a little bit faster. Other things related to lifestyle. So obviously if you do things that promote inflammation, like smoking, that's also going to lengthen the recovery process. The degree of the injury, so obviously it takes longer for a grade 2 strain or sprain to heal than a grade 1. And then the structure that's been damaged. So tissues that are more vascular heal faster and more completely. So for example, bones, very vascular, and so they tend to heal pretty well, as opposed to tendons, not so much, cartilage, not so much. And so both of those structures are either very slow in healing, or in the case of cartilage, cartilage inside of a joint, essentially, especially as you age, effectively can't heal itself. And so it just kind of, once you hit middle age, starts this process of slow degeneration. Similar information in graphical form. Trying to think. So mostly I included this stuff because I wanted to include this table here. So this is a pretty helpful little table. So it has all the different phases, or the 3 different phases, and then what happens in each. So this is a pretty helpful table. And then we'll talk about each phase here starting now. So like I said, the inflammatory response phase, give or take the first 3 days. We talked about the inflammatory response some with the tissue chapter in 202. So what happens there is let's say you damage a ligament. So with that, you're going to get damage not only to the ligament itself, but to some of the surrounding connective tissue. You're going to cause damage to nearby blood vessels, and near those blood vessels you have mast cells. And the mast cells are the ones that primarily mediate this inflammatory process. There are others. So tissue damage or damage to other types of cells also starts an inflammatory process. But basically, all those damaged cells release this soup, if you will, of inflammatory mediators that cause white blood cells to migrate to the area to clean up the damaged tissue, and they cause dilation of the capillaries and increased capillary permeability. So if we dilate the capillaries, it means we open them up. If we increase capillary permeability, that means that the endothelial cells, so the cells lining the inside of the blood vessels, they'll kind of pull apart a little bit, and that'll allow for the big cells like your white blood cells to leave the blood vessels and migrate into that underlying connective tissue, to migrate to the area where the injury has occurred. And as those big cells, those white blood cells, migrate into that damaged tissue, that also creates this osmotic gradient that pulls fluid with them. So basically, the combination of lots of big cells in the area plus capillary dilation plus increased capillary permeability, both of which are modulated by the inflammatory let's go with the inflammatory molecules secreted by damaged cells. All those things add up to swelling in the injured area, and so with that swelling we get pain, because you get the mechanical impingement of the free nerve endings. That causes pain. Some of those inflammatory mediators, things like histamine, sensitize the free nerve endings, which are your pain nerves basically, and so they're extra sensitive. Plus they have mechanical pressure on them. The redness is related to some of those inflammatory mediators as well. And so just during that inflammatory response phase, you got swelling, you got pain, and the athlete is not going to want to move the injured area. Then we move into the fibroblastic repair phase. So once the initial inflammation has subsided, once the macrophages have moved into the area and cleaned up the damaged tissue, then we have our fibroblasts, our immature connective tissue cells, migrate to the area, and then they're going to just start laying down collagen everywhere. So that's good, because that initial collagen scaffolding provides a framework that we can build on for the rest of our tissue repair, but that collagen that is laid down from those fibroblasts kind of just goes in every which direction. And if we're thinking about a ligament, the job of a ligament is to basically resist tensile stress or pulling apart. And so some of that initial collagen, those fibers may run at a 90-degree angle to the actual line of stress. So it's not super helpful, but we do have some additional collagen that's been laid down. So during this fibroblastic repair phase, that's where we want to be particularly cautious of not overdoing it, of having our athlete work through, starting with range of motion, which you'll see some in the inflammatory repair phase as well. We're going to have them do some range of motion. Once they've got good pain-free range of motion, now we'll have them start doing some resisted exercises. And we're going to start with isometric exercises, which is where they contract the muscle, but there's no change in joint angle. And maybe we'll have them do those at multiple joint angles. So, for example, with the lateral ankle sprain, you'll have them do isometric, let's say, E version of the ankle with the ankle in a neutral position, and you may do it with the ankle slightly everted, and then eventually you'll work your way back into inversion. And then, once we've done a bunch of isometric stuff, then we'll start working on isotonic, which is, it means same tension. So, like with your TheraBands, that would be considered isotonic, even though the resistance changes throughout the range of motion. We'll ignore that. So have them do some isotonic stuff, and then you'll work your way into different stability type exercises. So all that happens in the fibroblastic repair phase. And then maturation remodeling, so you can see that typically happens or starts at about 2 months post-injury. Didn't mention the fibroblastic repair phase, again, starts give or take day 2 or 3, continues for as long as 2 months. Then we move into that maturation remodeling phase, 2 to 4 months, can be longer. And so essentially what you're trying to do in the maturation remodeling phase is, in the fibroblastic repair phase, again, you have all this relatively weak type 3 collagen that's not aligned along the lines of stress. So it's, transverse to a ligament that is maybe sagittally oriented. And so with some loading of the ligament, then those collagen fibers will start to realign along the lines of stress. And so that's what we're doing both in the fibroblastic repair phase, but also particularly in the maturation remodeling phase. And that type 3 collagen gets replaced by a stronger collagen, which is type 1. That happens during this maturation remodeling phase. And so later in the maturation remodeling phase, we're trying to get not necessarily maximal strength, but closer to the strength that they're going to need to perform their sport. And then we'll start having them do more sport-specific exercises, moving at the speed of sport, those kinds of things. Talked about that. So this is some of the same stuff I kind of told you in terms of what we're doing during the inflammatory response phase. So we're trying to, allow the tissues to heal. We're trying to not cause any additional stress to them, trying to reduce swelling some to reduce pain. So typically during the inflammatory response phase, it's some combination of rest, ice, compression, elevation, not a ton of ice, but then also related to rest, we're going to have them do some range of motion stuff. So we do want to get them moving some, because the more that we can get them moving a little bit, then that's going to push some of the swelling back into the lymphatic system, and that'll hopefully help to reduce the pain. So other things to keep in mind there is that aside from the injured area, we can do things that don't stress the injured area. So let's say we have a basketball player that has a lateral ankle sprain. So obviously they're not going to be working the injured area, but they can still do like some upper body lifting. They can do, dumbbell presses, they can do lat pulls, etc. And then we can also have them do like the upper body bike or something like that. And the idea there is that they don't lose as much of their aerobic capacity as they would if they were just sitting around. Because as we talked about really early in the class, one of the first adaptations to aerobic training is an increase in plasma volume of the blood. And so going the other way, if they're deconditioned or involution, to tie this into some of the recent terminology we've used, if they decondition, then one of the first things that they lose is their plasma volume. And so if we can have them do aerobic exercise that doesn't stress the joint, like the upper body bike, hopefully we can have them hang on to their plasma volume so that hopefully when they are able to do more sport-specific type things in a few weeks, it won't take them quite as long to get back into game shape. Fibroblastic repair phase, so we're trying to limit muscle atrophy, so that's why we're trying to do some strength training as much as we can. Trying to limit joint deterioration. So like the joint surfaces, so the hyaline cartilage is nourished by the synovial fluid, and so that requires the joint to move around some to keep nourishing the cartilage. So if we have them not moving for a long time, you're going to get some deterioration of the joint surfaces. So the more that we can keep them moving, the less damage to the joint itself we're going to see. Now that said, with an ankle sprain, you're not going to have them like run on it. That's too much. So there's a little happy medium there. Some of the same stuff we just talked about. So in this phase, you can see sort of how them do isometric exercise, isokinetic exercise, which unless you have an isokinetic dynamometer is probably not going to happen. So then we'll have them do isotonics, and then we'll do neuromuscular control exercises are things like proprioceptive or balance type exercises. You can also, so I used the example of the AirX pad for an ankle injury. Similar kind of thing, if they have a shoulder injury, one of the things you can do for their proprioception is like have them lie on their back on a treatment table, have them stick their arms straight out in flexion, and then close their eyes, and then you can kind of apply gentle pressure, like tap their arm or tap their hand in different directions to help them be aware of where their arm is in space and to correct different position changes. So that would be an example of doing some upper body proprioceptive stuff. Maturation remodeling phase, now we're trying to get them back to sport. So again, we're going to start doing higher intensity strength training. We're going to start to do some plyometrics. We're going to start to move at the speed of sport, those kinds of things. And then we'll work our way up to doing more sport-specific drills. So, with our injured basketball player with their ankle sprain, we'll have them do some jogging to some higher intensity running to eventually sprinting. Then we're going to have them do some like low speed change of direction stuff that they can predict. Then we'll work into higher speed change of direction stuff. Then we'll work into like they'll have to change direction based on the coach's movements. So something they can't quite anticipate or that they don't know where they're going. They have to react to you. And then we can work our way up from that to now they have to do all that stuff while using a basketball, while dribbling. And so that's kind of how those things build on each other. Similar information in graphical form because I like to include all the tables. So here's one of them. Terminology here, so closed kinetic chain versus open kinetic chain. So closed kinetic chain, you can see, is that the terminal joint, which is the hand or the foot, in closed kinetic chain, it's fixed to something stationary. So, sorry, I switched to the terminal joint. So the distal joint is stationary. So the distal joint here, so the foot or the hand, is fixed to something immovable. So in the case of a squat, your foot's fixed to the floor. In the case of a push-up, your hand's fixed to the floor. So both of those are closed kinetic chain exercises. As opposed to open kinetic chain, the foot is able to move relatively freely. So this is open kinetic chain. Another thing you'll see with open kinetic chain would be things like running is kind of a combination, as we'll talk about here in a second. In the case of upper body stuff, open kinetic chain would be like dumbbell presses, because you're holding the dumbbell, but the dumbbell can move in all three planes, and so that's an open kinetic chain. Your hand isn't fixed to anything. And so here sprinting is both. So it's closed kinetic chain when you're touching the ground. So in this case, her left leg is in closed kinetic chain, her right leg isn't open because her foot is swinging freely. So between the two, the question to ask yourself is the hand or the foot fixed to something immovable? If it is, that's closed kinetic chain. If it's not, it's open. Program design stuff. So they talk about this DAPRE program, which is pretty similar to the DeLorme program. It just adds an additional set, and then it doesn't use a 10 rep max, it uses a 1 rep max. So there's another little wrinkle there, but it is pretty similar to the DeLorme program. So basically what you do is you do 10 reps at half of what you estimate their 1 rep max to be. So if you estimate that they can lift 100 pounds, you have them do 10 reps at 50 pounds, 6 reps at 75 pounds, and then the third set is, okay, I think you can do 100 pounds. I think that's your 1 rep max. Let's see how many you can do. And so if they only get 0 to 2, which is weird to me because that means you accurately estimated their 1 RM, you have to take some weight off for the fourth set. If they get 5 to 6, you leave the same weight, and then they get as many reps as they can on the fourth set. And then if they get 7 to 10, you have to add some weight for the fourth set, and they do as many reps as they can. So basically it's a third set of, let's see how many you can do with this weight, and then we're going to go up or down for this fourth set, which is also going to be a, let's see how many you can do with this weight. So basically there's 2 sets 3 and 4 of doing a repetition max. So just do as many as you can, or burnout is another way to think about that with each of those 2 sets. So that's what this is. Aerobic and anaerobic training. Obviously you want to mimic the demands of the sport, but early in the rehab you start with just anything you can do to keep them active, and then we work our way into being more sport specific. Injury risk stuff. So here's a list of specific injury risk factors for the upper body, injury risk factors for the lower body, and then a handy little chart where they apply these principles that they've talked about in this chapter to rehabbing a patellofemoral injury. And that is it. So that's all of chapter 22. So then next time we'll move on to facility design, which is chapter 23. So we will see you then.